Hospital CFOs, this is for you. Medical device reps, this is also for you. My team and I have worked with hundreds of hospitals across the country and hundreds of medical device sales reps. And one of the things that we found consistent was the implementation of new therapies and proper billing and coding and making sure that the financial engine works for everybody, because both the hospital and the medical device company both have to be profitable so they can continue to support the patients that they serve. Having reviewed claims for that long, my goal here today is just share with you the experiences that we've had, what we've seen, what's worked, what hasn't worked. And at the end of the day, after this, if you've seen something else that works or didn't work, please feel free to leave it in the comments. So here's how usually when I look at health policy and reimbursement, we'll get a call from a sales rep who says that the hospital says they're losing money. And the two things that I ask are, how is losing money being defined? And who is saying that they're losing money? Okay, so I'll give you some examples. And this happens every spring around March, April, when the financials are done for the previous year and various P&Ls are done, and the CFO is saying we're losing money. Of course, that could mean a host of different things, right? When throughout the year, we'll have various people from the hospital say that they're losing money. Who might that be? So is it the CFO, CEO? Is it the materials person? Is it political, right? Or is it just the hospital overall? So I'll give you an example. So we had a meeting with a hospital that was severely impacted by Katrina, and I'm dating myself. This is quite a while back. But what happened was they had wanted us to reduce the price on a particular medical device, and we were trying to understand why. Because per our numbers, they should be making money. And as we spent the entire day, finally, the CFO had said, look, here's the deal. Because of Katrina, we have to cut costs all across the hospital, and we're asking all of our suppliers to reduce 10%. That's a totally different conversation than we're losing money because of reimbursement, which was totally fine. And we were able to work with the hospital, and it worked out really well. So there are other reasons that sometimes reimbursement is used as an example for the hospital, just being open and honest with the rep. Once that happens, it moves forward very quickly. And med device companies want to work with the hospitals, obviously. Another one is CEO of another hospital was saying they were losing money on reimbursement. I've done the numbers 100 times and I just couldn't understand how they were losing money. And so I asked the rep not to discount anything until we find out exactly what's happening. When we had the meeting, it seemed like no amount of discounting was going to satisfy the hospital. And ultimately, what we found once we had a confidential conversation was that there were some issues with some physician contracts, and they didn't want to lose some procedures, but did not want to implement any new ones. And so it was truly a political situation from there. Again, it wasn't reimbursement, but reimbursement tends to be a very easy out, so to speak, from the hospital perspective. But then on the hospital side, really interestingly, and CFOs, if you could align your incentives appropriately with your supply chain managers. So we've run into this quite a bit, is that the supply chain manager will tell us we've got to come down in price, or tell the medical device manufacturer to come down in price. Usually they'll mention reimbursement. Sometimes it'll be competition, but reimbursement is typically it. It's been my experience that supply chain managers don't know as much about reimbursement as I wish they did. And any of you listening to this that happen to be supply chain managers, I'd be happy to teach it to you. Some of the supply chain managers that I've run into, their incentives, their bonuses are based off of how much they reduce supply costs at the expense of profitability, meaning that it doesn't matter in their paycheck or their bonus how profitable the hospital is. It only matters for their incentive to reduce supply chain costs. So we had this situation where we're going round and round, and the math was very clear that the hospital had a profitable procedure that they were doing, and they wanted pricing to come down due to reimbursement. And finally, the supply chain manager said, well, we're going to shut this down, this procedure down, this therapy, the device down, and not do any more procedures unless you come down a particular amount in price. And it just didn't make any sense. And so the conversation turned to, well, if you're making money on all of these cases, you should be asking us to find more cases for you, because you're making profit on it. And to shut it down because of the incentive for that person's bonus, was a little short-sighted. And so as we had a broader conversation, it became very clear what was happening, and we were able to continue offering therapy there. Don't know if the incentives changed from the hospital perspective, but I have run into that quite a few times. And so to your reps, when you hear that the hospital's saying they're losing, it really comes down to who and why. And I wouldn't discount the device costs until I understood why. And it's really important because let's just say it's billing, or the coding's being done incorrectly. And so the hospital's saying we're losing money, um, because we're not getting as much as we thought we were. And then you've got a discount, and then you find out that they just weren't coding properly. So again, everybody in that whole entire supply chain, including the physician, all has to have a sustainable economic model to continue to deliver. Okay, a couple other things to keep in mind, right, is defining losing the whole hospital, like I explained with the Katrina. Is it just a particular department, or a modality, just that particular type of therapy? Is it like a P&L on that doctor, or is that doctor making the money or not? Is it Medicare versus Medicaid versus private payer? Is it per case, each individual case, or is it per patient, so the total cost of care on a per patient basis? All of those are critical in understanding what the med device rep can and can't do. So, for example, I mean, imagine that the hospital overall is losing money and is in financial straits. And if the device company reduced it to zero, the cost of their device, would that even move the needle for the hospital? So again, reps understanding what exactly is driving the conversation, and then for the hospital, understanding how you're defining losing so that the med device rep can actually help you, because there aren't a lot of triggers for them to pull, but one of them being bring in a reimbursement person to review the claims, not to get anybody in trouble, but to make sure that it's being done properly. So those are how I look at that. So to restate, how are we defining losing money based off of reimbursement, and who is saying we're losing money? So if both sides kind of come to that, we're comparing apples to apples, that becomes a very quick conversation. The next thing that I look at is getting down into the details. So at the end of the day, the entire financial model comes down to claims that were submitted to insurance carriers, copays, all of that kind of stuff. But really, it's the claims. So then I ask myself, okay, on a particular claim, I would ask this, did the hospital get nothing, or did they get something? And the reason I ask it that way is because if you got nothing, right? So you're looking at the EOB or the RA and zero, you got zero. The thing that would be really important for me to look at would be, um, did the case get prior authed for both the doctor and the hospital? So that location. And then I'm looking at the diagnoses codes. So was this code an appropriate code for this therapy? Sometimes I've just seen typos of the diagnoses codes, and there can be a disparity between what was prior auth and then what showed up on the claim form. So imagine you've got a particular diagnosis, in the prior auth, a specific location, a specific date range, all of that there. And then when you submit the claim form, one of those pieces of information does not match with what the authorization was. You can imagine then they would decline it, and you've got to figure out exactly what's going on with that case. So that can be very challenging from that perspective, but part of it is just checking the documentation and checking it timely. I would do a quarterly review, just because if you wait till the end of the year, or when CFO, you're doing the financials for the previous year, there is a limit to how long you can submit original claims or submit corrected claims. And so the longer you wait, the less opportunity you have to submit a corrected claim, should it just be a typo. I've seen typos affect $20,000 per case in reimbursement to the hospital. That is devastating. So I would take that time. So trying to justify doing a review every quarter, if you just catch one of those at 20K, totally worth it, right? And just I would spot check the major, most costly therapies to make sure that everything is correct. I'd also check if it was zero reimbursement, how the payer policy is and what they're saying can be done. So, for example, if they've only approved an outpatient and you did it inpatient or vice versa, that could be a situation from a payer policy perspective where they had different dollar amounts than what you were expecting. Actually, that would fall under some reimbursement. So if you got zero reimbursement, I'm checking all the elements of the prior auth versus what was submitted on the claim form. That's really what I'm looking. And I'm looking for if it shows experimental and investigational. Typically, when I see that, I'm looking right at the diagnoses code to see if that is a covered diagnoses code for that therapy. I'm not telling you what diagnoses code to use. That's a medical decision. But I'm looking to see if there's a difference there between those two documents, the prior auth approval and the claim form that's put there. And you may just have to change the diagnoses because it was a typo and put it together. But again, I'm not telling you to change diagnoses to meet payer policies. So now let's just say you got some reimbursement. We did not get what we thought we were going to get. The device rep came in and said, hey, you're going to make all of this money and here's what it looks like and da 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 da. And then you come back and say, well, we didn't get what you told us we were going to get. So there could be quite a few situations that would lend itself to that. And I'll just highlight a few. And if you want, anybody want to reach out, happy to have a deeper discussion. But sometimes not all the CPT codes were put on there. I'm assuming hospital outpatient for this, obviously. So they're not putting all of the CPT codes that were done, or the bundling had a negative effect on what you thought you were going to get. I see that quite a bit. Or let's just say that some of the codes require, especially if you're doing two procedures that are the same, like a bilateral procedure, some of the payers, Medicare, might want a 59 modifier on the second, and private payers, maybe they want a 51. Right. And then sometimes I'll see claims where it'll have that procedure, that bilateral procedure with no modifier and just ×2. Right. And so then you miss out on that second one. So those nuances become extremely important when it comes to billing. Again, I've seen that happen so many times. And I get it. It's almost impossible to keep up with all of the codes. They change every year. Policies change all the time. For a prior auth and coding team in a hospital to keep them updated and trained is a big investment. And I understand that. I would not skimp on that. It is so important to make sure that everybody's up on the latest billing and coding. Okay. The other thing that I see in some therapies, especially implantable device therapies, is the op notes versus the CPT codes. So for example, let's use implantable pulse generators, and there are codes specifically for that, 63685, for example. I have seen, or we have seen, our experience has been that some coders, especially some of the new ones, they're trained in a way that says they're looking for these very specific words that are in the operative note versus what's in the CPT code book to make sure that they're translating it properly. And I can tell you in CPT training that it is strongly impressed upon people that you don't want to upcode and downcode, but you definitely don't want to upcode because there could be recoupments, there could be audits, all of those types of things. So I can tell you, CPT coders, we end up having a mistake on the conservative side than on the aggressive side. What'll happen is the doctor will use like the brand name of the device that they're implanting. So instead of a IPG saying an implantable pulse generator, which is in the code, they'll use the name of the product, whatever that name might be, call it Jones device. And they'll say implanted the Jones device. And then the coder will look at that and go, I don't know what that is. I can't bill for the IPG. And they don't put the code there. Now, what should happen in that situation is that coder should feel confident enough to talk to their supervisor and then check with the physician what exactly was implanted. I've seen that communication break down quite a bit And so it's not easy to expect a coder to do that, especially when they're going through hundreds of procedures that they're trying to code and get everything coded properly. So there can be a disconnect there. What I tell the reps in that situation is help the doctor understand that when they're putting in the brand name, that's not helping getting proper reimbursement to in the operative notes, put in the actual CPT words, which in this case would be IPG. That becomes very important. Another issue is the build amount. So what folks, let's just say the rep comes to you and says, hey, the reimbursement on this is $20,000. And you're like, okay, great, it's $20,000. And then you get, when you submit everything, you get 15,000 and you go, oh, what happened? And so when I see that situation, there are usually two situations that come up, one of two things that have come up. One is understanding the billed or contracted amount, right? So insurance companies, including Medicare, will pay the billed or contracted amount. So let's just say Medicare said it'd be $20,000, and for whatever reason in your charge master, you were billing it at $15,000. So if you bill it at $15,000, they're not going to just pay you that extra $5,000. It's a lower billed or contracted amount. Private payers do the same thing. So the first thing I do is just double check the fee schedule that you've contracted with for that payer to make sure that you're billing it appropriately. If they say it's 20, they'll pay you 20 for it. You only bill them 15, they're only going to pay you 15. So I would really look close at that. The other thing too that go into the amount, one, it could be the coding like we talked about, but two, it could be two other things, two sub pieces there. One would be the 80/20, we'll say Medicare. So most Medicare patients, they'll have 20% copay. They'll have some supplemental, but nonetheless, it'll be less than what the total amount is that the rep talked about, that 20K. You say, okay, well, 2,000 or 4,000 is the patient's responsibility. So you'll get that 16 or 18,000. And so that's how that works out. Then if we don't expect we're going to get paid, I hear this, that, we don't expect we're going to collect that copay. So I need you guys to come down in price. Well, obviously there are a whole bunch of regulations around appropriate collections, especially for Medicare, and making sure that that's followed. But to expect a rep to make up the difference of a hospital not able to collect copays would be an inappropriate ask and something that's prohibited. So I wouldn't go down that path. And then there's in-network, out-of-network. You have those variances. C code tracking, so making sure all your C codes are on there, making sure that the dollar amounts are applied to the CPT codes, not the C codes, because it's based off of CPT codes. And then the national base rate. So when a medical device company brings a price to you or a reimbursement amount to you, it's typically the Medicare national base rate, right? What that does not include typically, now some have this, is the wage index adjusted amount, right? And for those of you who understand that, in different parts of the country, it's more expensive to deliver certain therapies than others. And so the reimbursement varies, as well as reimbursement from a hospital, especially for Medicare, regarding, do you have special reimbursement for rural, for urban, for education, for quality metric reporting. You have all of those elements that go into it. So it won't be exact, and the med device company will not be aware of all of those elements of your hospital. So at the end of the day, what it comes down to is just sitting down and having the conversation, everybody having that conversation, to make sure that this is a sustainable therapy, economically speaking, assuming all the outcomes are good. And it's safe and effective and reasonable, necessary, all of those things. But assuming that's the case, there needs to be a sustainable economic model for everybody to continue to deliver a particular therapy. A couple other things I would say is off-label versus on-label. This would be for typically non-prior auth procedures. For the hospital staff, be very aware it is very difficult for a medical device rep or company to discuss off-label. That would be very inappropriate. They do not, medical device companies go to great lengths to make sure that there is no off-label promotion of their devices. And if you're not sure what that is, basically when they get their FDA indication or approval, or clearance, their indication specifies exactly how they can sell it. So for example, for a spinal cord stimulator, if they were to sell it on migraine, that would be inappropriate. But let's just say the doctor decided that off-label they were going to do migraine and reimbursement didn't happen. You're going to want to make sure that that is a conversation to have with the doctor. To be very difficult to pull the rep in because it'd be prohibited from discussing those off-label scenarios. Experimental investigational, that's a big one that I see, and that is the dumping ground for everything. So if any of this stuff, if there are typos, if there's just miscommunications, it's usually just a junk drawer of experimental investigational. And so that doesn't mean that the device is not FDA cleared or approved or not covered. It just means that in the combination of procedures, diagnoses, codes, site of service, all of that, if they're not aligned properly, that the payer may say, well, this is experimental and investigational. So typically it's a diagnoses code, quite honestly, that seems to be the issue. But hopefully that was taken care of in the prior authorization. Okay. Bundling versus not bundling. I see this quite a bit in hospital outpatient. So we'll use SCS as an example, spinal cord stimulators. The two leads, and there's typically an IPG and two leads that are implanted in the permanent procedure. And the total dollar amount for the two leads and the IPG are actually allocated to the IPG. And what that means is that dollar amount is to compensate for the two leads and the IPG. Some folks misinterpret that to say we're losing money because we're not getting paid for the two leads that are put in. That's not correct. What that means is that there's just some education that needs to happen there to understand that the total dollar amount for all three of those devices goes on to the 63685 line. So it's a bundled payment, unlike in an ASC, which is separate. Okay, so when I see CPT coders go between hospital outpatient and ASCs, and I know a lot of hospitals own ASCs, that becomes an issue. I've seen coders switch and think a hospital coder going to an ASC think that everything's bundled, and what they do then is they don't put on there the two leads. It's just the IPG, and then they miss it in the ASC, so they miss that additional reimbursement. And then in the hospital outpatient setting, sometimes if they take out the two leads, then that's inappropriate billing, right? That would be down coding, I guess, in the sense that you're basically telling the payer that all they got was the IPG implanted because you're just not including the two leads. And that can cause problems later. Imagine if the patient has to have those leads removed, you go to get prior authorization and the insurance carrier says, we've never seen that the leads were ever implanted, right? And so how can you remove stuff that isn't there? And then you'll show them the fluoroscopy and they'll say, well, they're there. And they say, we have no record of those being there. So that's really, really important. Make sure that that's done, that all those codes are put on there. That becomes really critical down the road. So this goes a little bit beyond just the reimbursement piece. It goes into how reimbursement affects your business, right? And a hospital is a business, and how some of these small, and what I look at is just naive, meaning not understanding certain things like bundling, how that can negatively affect procedures down the road. And obviously we all want to take care of patients for the long term, right? Especially the chronic pain patients, or any chronic condition patients. They're going to be coming back and you want to make sure that they're well taken care of. Okay, so we talked about op notes, making sure that they are the same with the claim form. Just paperwork is basically what it comes down to, that needs to be all connected. Are you billing the appropriate amount? So checking your charge master that you're billing the appropriate amount, and your fee schedules all work out to make sure that you're making what you're supposed to be making, that you're taking into account copays, you're taking into account whether these procedures are in network, out of network, taking into account timely filing and correct claims filing, taking into account C codes for tracking of these devices. So all of those things are really important. So what do? I know there's a lot of information. Again, if you want me to create kind of a checklist for this, I'm happy to do that. But here's what I would do. Okay. The first thing I would do is I would bring in the med device reimbursement person. Every medical device company is going to have a reimbursement person, and that person is 100% motivated to make sure that surgery centers, hospitals, physicians all get paid what's appropriate for this therapy. And I understand it's been our experience too that, can we trust the manufacturer giving us the correct information? Look, what I'll tell you is, and you should look this up, AdvaMed Code of Ethics is fantastic. Section 11 talks about reimbursement and that a med device company or even consultants can only give you reimbursement information if it's correct, and you have to follow a code of ethics. Great code of ethics. The industry has been following that for 15 years at least, and they're not going to tell you something wrong. They will help you. And some folks say, well, are they going to charge us for that? And I say, well, no, they're not going to charge you for it. You've already paid for it. So when a medical device company puts their pricing together, they could take into account all of their costs, R&D, cost of goods sold, selling, general administrative, accounting, legal fees, clinical studies, all of those things, including reimbursement advice. And so you've already paid for this through the cost of the device. Absolutely utilize this service. Every company has it. They want to meet with you to make sure that you're getting the money that you're supposed to. What I've seen, especially from a coding department, that maybe just a little bit of insecurity around, hey, if we're doing this wrong, last thing we want to do is get in trouble. Totally understand that. We've met with just the team by themselves, and we don't even have to tell anybody. It's just for their education. Sometimes we just do reviews. It just kind of depends, but please have the medical device reimbursement person come in and have a conversation with you and share with them your information. And here's what I'd share with them. And you may not want to share all of it, but here's what you need to know as a hospital leader, especially the CFO, CEO as well. There are a couple things that I want to look at when I'm talking to a med device rep about, hey, we're losing money on your procedure. Okay. The first thing I'm doing, I want to see a copy of the prior auth approval. First, I want to see it's approved, and I want to be able to pull from that the approved diagnoses, the approved CPT codes, the approved C codes, and the approved site of service and physician, and the approved date range for that procedure. So that kind of sets the table for everything. Then I want to see the operative notes. So the doctor's operative notes, I really want to see that. Remember, I'm looking for if they used a brand name in the operative notes, and that confused somebody. I'm also looking for quantity and the types of procedures. Some procedures have limits, and sometimes coding self-corrects for that. That shouldn't happen, but nonetheless, I'm looking for those details within the operative notes. The next thing I want to see is the claim form. And so now I'm going to take the inputs of the prior auth approval, the operative notes, and all of that will manifest itself via diagnoses codes and site of service and physician and all of that on the claim form. And I want to make sure those three things or those two things are represented appropriately in the claim form. Then I want to see the EOB or the RA, so the explanation of benefits or the remittance advice. I want to see in there, okay, did we get something or did we get nothing, right? So that kind of goes down two different directions, right? And so I'm looking at that and I want to really understand, is what I put on the claim form the same? Are they addressing the same thing? Are all of these things in line? Because half the time it's just typos or a misunderstanding, and making sure that that's filled out properly. So I'm looking at that EOB, and then I'm looking at payer contract. So let's get the payer contract. So let's just say you're working with one of the private payers, and did you bill them the appropriate fee scheduled amount? Is your charge master correct? Has it been updated? We have seen that where it's a brand new therapy for the hospital and the charge master hasn't been updated yet. And you've got some issues with timely filing and people not understanding exactly how to do it. Then the last thing I'll do is get with the rep and get the invoice for that procedure, right? Because that rep is absolutely accountable for all of the devices that leave their possession. So if they're in the OR, they're writing everything down. And also they want to make sure that the company understands what actually has been implanted. And we need to be able to track devices that go into patients. And so they're very, very accurate. Otherwise they get personally held accountable. So they're going to make sure that's correct. So I take all of that information and I'm correlating it together to say, okay, is this working or isn't it? Right? I mean, it becomes really, really critical to look at the details of all of that. So when I think through we're losing money. That question or that statement from a hospital system, it's in summary, it's just how are we defining it? Who is defining it? And how can we go into detail to help make sure that reimbursement's what it's supposed to be, and or work with you on price, right? I mean, there's all of those things that come down to it. I can tell you from experience, typically the cost of the device is a small percentage of the overall cost of running the hospital. I think Medicare statistics were at like 5%. So at the end of the day, the device folks can only do so much. There's only so much room there. And I don't want you to get wrapped around the axle around they can solve all of these problems. I've found systemic issues in many hospitals where we have, and there are opportunities for improvement. And I don't want missed opportunities to happen. And then folks kind of go at each other, and then we have these issues, and it's almost like marriage counseling, and you try to move on, but better thing to do is to be talking up front. So if this was helpful, I hope it was. Please feel free to leave a comment. Let me know if it was helpful, if you want to see anything else, or if you've experienced something in your day-to-day life that said, well, we've run across X, Y, and Z. I think that would help a bunch of people. The objective here, again, is to make sure that the financial engine is working for everybody so that patients can get access to these therapies who really need them. And these devices can really be life-changing, if not life-saving for many patients. Happy to help any way I can. And if you're a patient seeing this, that's how the whole system works. Any questions from that perspective as well. But good luck, everybody. I appreciate your time. Thank you.